Good day. I'm John Supplett, Senior Director of Rural Health Services for the American Hospital Association. Today, we will hear the story of hospital heroes caring for COVID-19 patients at King's Daughters Medical Center, located in Brookhaven and serving Lincoln, Lawrence, and Pike counties in Mississippi. A little background. KDMC is a not-for-profit, 99-bed, sole community hospital serving a disproportionate number of Medicare and Medicaid patients. It provides a full scope of inpatient acute and emergency services and operates 5 medical clinics providing primary and specialty services to the almost 100,000 people in their service area. Alvin, I know you are in the thick of the battle against COVID-19, but there's much our rural hospital colleagues can learn from your early experiences. Thanks for taking the time to share your story with us.
Thank you, John. I'm pleased to share our story, and I hope that others can benefit from it. I hope they don't have to, but, this is one of those things that you have to be ready for, no matter where you are, no matter when it is.
Great. Thanks very much. Alvin, by March 23rd, KDMC had tested 84 individuals and had 5 positives for COVID-19. Governor Reeves ordered residents to stay at home on April 3rd, but by then, KDMC already reported more than a dozen COVID-19 positives. How did COVID-19 reach Lincoln County so quickly?
I think it happened here as a result of spring break. A lot of people traveled out of town. We had people in Greece and France and Spain that came back in from spring break that second week of March. We had people that went to Colorado skiing, and there were several that were in those 2 or 3 hot spots in Colorado. The following weekend was Mardi Gras. You heard how New Orleans has become a hot spot. There were people from Brookhaven that were down in New Orleans for that celebration, and coming back to Brookhaven unaware really that they'd been in contact with it, it really hit our population pretty quickly.
Alvin, COVID-19 reached Brookhaven so quickly that you established a mobile screening site behind the emergency room to manage the demand and keep people safe. How did you come to this decision, and how is it working?
We set up a COVID team probably around March the 16th or 18th, whatever that Monday was, and we started meeting just a couple of times that week. By Friday, we went into meeting every day mode, and I don't remember exact date, but that Sunday we said we need to have a mobile screening site. We picked up 10 or 12 tests a day out of our primary care clinic, and we felt that we were just bringing too much risks to the regular patients that came into our clinic, exposing them to COVID when they didn't need to. So we set up a mobile clinic site. We set up a phone number to go with it, 4 different lines coming into one so that we could do the screening calls. We set up a couple of LPNs to take those screening calls. At the peak of it, we were getting 150 calls a day and bringing in 30 or 40 people to actually screen and testing. Again, at the peak test that we did in a day was about 30 actual tests in a day at that one mobile site. Having the mobile testing site really took a lot of pressure off the ER, a lot of pressure off the clinic, gave our community an easy access point for their fears and worry and potentially to be tested for COVID.
So you were very proactive in your preparations for COVID-19 and coronavirus, trying to get ahead of it as well back as December. With respect to it exhibiting itself in Brookhaven, Monday, March 16th, you're starting to get requests for tests. By the end of the week, you're meeting every day to discuss your plans for meeting the demand for tests. You're now moving and mobilizing a screening site to keep people safe and to meet the demand. And all of this was done up front very early and actually prior to the governor's stay-at-home order. As of April 13th, you had performed 417 COVID-19 tests with 52 positive. How are you able to keep staffing the hospital and stay up with the demand of this growing surge?
As far as staffing goes, we've got an 8-bed ICU. We typically staff for 3 or 4 patients, and we haven't had 7 patients in our ICU since the 2 midnight rule started. So we've had to train nurses to bring in more experienced medical nurses, put them with an experienced ICU nurse, work a shift or two, and then guess what? They're on their own shift, maybe working their own patients without watching somebody. It's maybe a little uncomfortable for them, but we feel like they're prepared. We feel like they're experienced nurses. There's plenty of help around for them to ask questions, and they've been trained appropriately for the equipment that they use. But it's rapid fire. It's a faster orientation than we typically done in hospitals. But we're in a crisis, and we've got to find the people to work. So staffing the ICU has been problematic. On the COVID floor, the rest of it, we turned a whole third floor into a COVID floor. So we moved our regular medical patients down to the surgical floor on second. We're still running 12 or 14 surgical patients like we normally do, but we've added this influx of COVID on top of it. We're still delivering babies. We deliver 60 or 65 babies a month for the most part. That's going on like it normally does. Inpatient surgeries are happening, but elective surgeries have stopped. If somebody has an urgent need for surgery, we're taking care of that, but it has to meet the criteria to be urgent. And so we've been able to take some of the nurses from surgery and put them to work on the floor. We've taken some of our nurses and clinic and front office staff from the clinics that we run and put the nurses on the floor doing some supporting roles versus direct patient care. And then we're using the clerical staff at the nurses station to support in roles there.
So your staff is cross-trained. They're functioning at the top of their license. Everyone's pitching in, doing duties as assigned. It sounds like you've really coordinated the effort across all departments of the hospital to address the crisis.
That's correct. The COVID team that we put together includes doctors and nurses, but there's other supporting staff there. Of course, our CFO participates in that. Our materials manager's there. We've got some marketing there because we're not only reporting this for the hospital, but we're providing a web page for our community about what's going on. And a couple of bright spots out of that are that we've had a great community effort to make cloth masks for us. So over the last week or so, those orders have started coming in, and we're in a pretty good spot with PPE, particularly as our census had dropped. We've probably got 3 weeks worth of PPE across the board now.
How about the ventilators and other equipment that's necessary to build the capacity to treat this surge? Did you have to improvise?
Beg and borrow. I'll leave off steal. We didn't steal any ventilators, but we begged and borrowed. We have a hospital close to us that does some long-term vent care, or the intermediate vent care. So they take patients that are no longer acute and begin the weaning process for them, and they've loaned us a ventilator. We have 5 adults, so that gave us 6. We did scrounge around the hospital. We found an old, they call it an old bird. It's probably one that we took out of service 10 or 12 years ago. And sometimes in rural hospitals, you take something out of service and the guy says, we'll use the parts for that somewhere down the road. We sent it off, got it refurbed, and it's ready for use. So we've got 7 adult ventilators. We've converted some vents from the anesthesia machine so that they're available for vents. They're not a full service vent. You can't really do anything other than provide the air. You can't regulate pressures and do the more complicated patients, but you could use it for vents. We had 7 vents going the other day. That was a pretty scary time for us because, we were maxed out on adult vents at that point. We've got some transport vents, the anesthesia vents that could help. And we put in a policy in place to talk about scarce resources that scores your patients based on comorbid factors.
Alvin, I can hear the care and the concern in your voice, and you now have to look forward, having eliminated elective surgery, and your inpatient and outpatient volumes are cut by half. What do you do to assure access to quality of care in Brookhaven once this crisis abates?
John, that is the $1 million question. There's still so many unknowns. This week we got our first grant payment out of the $30 billion that's available. It's about 7 days cash for us. So we're still trying to figure out what that really means to us. We just finished our March financials, and for us, the first 2 weeks of March were off the charts. We were having a great month. And, so the last 2 weeks, the order came down to stop, asking you to stop elective surgeries. Well, did that mean today, or did that mean the end of the week, or what? And so we worked through that over the course of the week. We really decreased our number of elective surgeries, probably didn't stop them all until the next week. So we had one real bad week in March. And so our month, wasn't as bad as I thought it was going to be. It's still a negative month. We didn't cash flow for the month. That 7 days of cash comes in handy there because we used 2 or 3 of that just in the first month without all the impact. April's going to come around, and boy, it looks like it's going to be a big, big loss because there's no elective procedures going on. There's very little business in our clinics. So we're trying to figure that out. We applied for accelerated payments, and that's a catch-22, right? It's immediate cash, but you're going to be paying that back over the next year. We've applied for the deferred payroll tax. You're going to be paying that back for the next 2 years. How does that really impact your financials over time? And so this crisis, it has a lasting impact.
Alvin, how is the trauma taking a toll on the emotional well-being of your staff? And what can be done to help them through this crisis?
Well, it does take a toll. Early on, you saw it just in the stress, and there were moments of tension between staff that we don't usually see. We've got a great chaplain here at our organization, and we have an EAP program if they need it. In rural America, I think most hospitals look at their staff as an extension of their family, and we certainly have that attitude here. We take care of each other.
Alvin, the disruption of COVID-19 clearly has altered the terrain of KDMC and the work that you're doing in Brookhaven and your surrounding counties. One final question. Your early experience has been invaluable. What advice can you give your colleagues that will help them prepare for COVID-19?
Well, I guess the first thing I tell you is don't think it can't happen to you, because it certainly can. And it can happen to you. You got to be prepared. It's what hospital operators do. You anticipate the challenges that you have. You practice for disasters and things like that. And the COVID outbreak, you have to take what you've learned from other disasters and really throw it together, as well as continue to be adaptable and flexible, to be able to make decisions on the fly, and certainly to embrace change, because it happens at a fast and furious rate. And it's been a challenge. Early on, we furloughed about either partial or full furloughs for about 70 people. And then we had another 70 or 80 people out of our 650 employees that we've cut their hours, reduced their hours somewhat without furlough. But we've impacted at least 10% of our workforce, if not a little bit more, to have reduced hours. And where we can put those people back to work, we're trying to when those needs arise.
Right.
John, I think one of the most important things to do is don't think that you're going to have to answer all these questions by yourself. Call your colleagues and talk to them like we do in rural health. We depend on each other to know what's going on, and we don't have to come up with our very own solution. Somebody's done something like it. We may be able to tweak it, make it a little bit better, or somebody may have the perfect solution out there. But if we depend on our colleagues and talk with them, ask them how they've handled it, or if they know somebody that has, they can be a tremendous resource for us.
Alvin, KDMC is resilient and resourceful. It's everything that we've come to expect from our rural hospitals during a crisis. The strength of rural healthcare is critical to the fabric of American healthcare, and it's our mission to safeguard it, improve it, expand it, and advance it for future generations. On behalf of the AHA, thank you to our country's healthcare providers for their hard work, dedication, and personal sacrifice in this trying time. And thank you to hospital and health system leaders like Alvin Hoover, CEO, and the nurses, physicians, and all healthcare heroes caring for patients at King's Daughters Medical Center in Brookhaven, Mississippi, and across rural America. This is one of several stories of how rural hospitals are rising to the challenge of COVID-19. Visit our website at www.aha.org to access these and other COVID-19 resources available to hospitals and health systems. Thank you. I am John Supplett. Be safe and stay well.